I'm talking today to Maeghan Orton of Medic Mobile. Maeghan, what does Medic Mobile do?
We are a non-profit IT firm that specializes in building solutions for rural and disconnected clinic settings, and specifically the users that we build for are patients, community health workers, and clinicians that operate in those challenging settings.
So which countries are you working in?
We have active projects in 20 countries in Latin America, North America, South Asia, and also Africa. Specifically to highlight a few of the countries that I'm actively managing programs in, it's Malawi, Kenya, Benin, Mali, Senegal, and then we have some new projects starting up in the DRC.
And globally, how many people are using the system?
We have 6,000 active users, and they use anything from our core product, which is this microprocessor, which allows you to collect structured data using SMS, and then also structured SMS.
And that thing you've just shown me fits behind the SIM in the phone?
Yeah, I think of it kind of like a jigsaw puzzle. So we actually physically cut out a small 10 centimeter square from any SIM card, and then the little microprocessor fits in like that, and then that goes directly into even a very, very basic mobile phone. The system can run on Android, on Java-enabled phones, and then also on the very, very basic $10 phones. The only system that it can't work on is iOS because it has a micro SIM.
And typically what kinds of information are you collecting for what purposes?
The use cases are many. We have referrals, so some patients are coming from a rural disconnected clinic all the way to a central referral facility, and we have systems that allow you to send patient data from that very rural setting to the referral clinic, and then to receive confirmation messages when that individual arrives. But also you can collect structured data up to 200 data points for health systems monitoring, anywhere from disease surveillance to patient data to lab results. So it depends specifically on the requirements of the project and the partner.
And at the moment it's all effectively SMS based. So.
Everything that we send is SMS based, yes.
But presumably there will come a time when it will be possible to use smartphones and maybe Android phones. What's the reality of that at the moment?
At the moment, in the communities where we work, I'll give you an example in Kenya. Currently, health workers in Kenya, according to a study that was just published in the British Medical Journal, 100% of health workers have mobile phones, but of those health workers, less than 10% have a phone that is an Android phone and is connected to the internet. And again, of those health workers that have mobile phones, 99% of them are using SMS on a daily basis. So what we build for is the current reality of the health system, which is that right now health workers have mobile phones in their hands, they're comfortable and they know how to use them, and the connectivity in terms of the networks is optimized for the SMS-based platform. The internet connectivity is not a stable reality in the majority of the areas that we work. The internet can come once a day for 15 minutes, or it can come in the morning and not in the evening. And if you're looking at sending time-targeted information to a centralized facility or to a Ministry of Health, it's ideal for that information to come in near real time as opposed to waiting for that connectivity.
But there will come a point, won't there, where internet connectivity is more widely dispersed. And then the argument surely would be that it would be a good thing to distribute the equivalent of Android phones to all of these professionals.
Yeah, I mean, it's a great question that you raise, actually. A lot of the individuals that we work with, the clinicians and the community health workers, are either highly underpaid or not paid at all. And so the challenge comes if you have a nurse in Kenya, for example, who earns 25,000 shillings, that's approximately $290, and she receives a phone that is worth roughly 10 times more than her monthly salary. You have to look at that question and say, there's a lot of temptation.
Yeah.
And also you have to look at how she would use that. Are you going to block Facebook? Are you going to block Twitter? Are you going to start to micromanage an entire health workforce to ensure that they're using data only for the appropriate purposes? I actually asked a really great question that we have often is how do you ensure that community health workers have enough SMS-based credit? And so I went in and actually spoke to community health workers, and I said to them, tell me, if I gave you $1 million worth of credit, what would you do with it? How long would it last? And they said, we would spend it in a day. And that's also the reality, is you have to look beyond just the device, you have to look at the implementation infrastructure. So what we've done in our pilot, where I asked those questions to the community health worker, is we've started a micro enterprise where the community health workers receive very high quality solar chargers, and then they charge their neighbors' phones and receive 10 to 20 shillings per charge. So that results in a household income of about $20 to maybe $40 a month. And the instruction is that they can keep that money. They only have to spend the money required for the reporting without it coming down from the central level. And that's actually worked incredibly well. The maximum cost of our system on an individual basis is 30 shillings per month, which is less than 50 cents. So if they're making $20 and we ask them to spend 50 cents, up to this point that's worked really, really well.
So you're creating an incentive effectively?
We're creating an incentive, and we're creating a structure which can be sustained without our presence.